respected chairpersons and lauded audience. My talk is Snuff PCI, small is beautiful. Practically, it is nothing but transradial approach, and we have to know regarding introduction, brief history, anatomy, advantages, disadvantages, evidence, favored distal transradial intervention, hemostasis techniques, some interesting procedures, and take-home message and conclusion. An introduction, if we tell the distal radial approach is most recently introduced approach of radial access in the world, seems to be attractive for safety, profile and fewer complication. And this approach has some potential advantages over radial, conventional radial approach, and rates of vascular complications including radial artery occlusion, radial artery spasm are less frequent. And the person who started this procedure in the world, he is this Babunashvili, and the intervention started by Kimenji. And in Bangladesh, we have started in 2017, 3rd December. There are two sites where the pulse of radial artery in the dorsum of the hand can be felt. The first one is in the anatomical snuff box, and second one is intermetacarpal space. And you see there are vast vascularity in the hand, and there is well collaterals in between the two arteries. And the anatomy of this radial snuff box is a bit difficult job, but we do not need to know the anatomy, but we must have to know there are medial border, lateral border, proximal border, floor and roof. And this is the anatomical snuff box. And right distal radial axis, the right upper arm is positioned in semi-pronated manner to access left distal radial artery. The left hand is bent over towards the patient's right groin over the abdomen. And after local anesthesia, as like that of transradial approach, 21 gauge open needle or cannula at an angle of 30 to 45 degree in a lateral to medial direction. The needle is directed to the point of strongest pulse, proximally in the anatomical snuff box, and here to and fro, that is total, we do not usually do double wall. Here we shall try to do single wall, as because under the bronze there is the bone and there may be pain if we touch the periosteum. After successful puncture, a flexible soft J-tip wire is inserted, and over the wire the radial sheath is introduced. And this is the radial sheath introduced into the anatomical snuff box in the dorsal radial artery, and this is the way why we should go to this side branch. And this is the important slide to preserve the radial artery for subsequent intervention if necessary, for using radial artery as conduit for CABG, for making the arteriovenous fistula in CKD patients. Radial artery spasm is less and less chance of hematoma and lower time to hemostasis and less late lumen loss, well tolerated by patient and increase patient satisfaction because of less pain and less radial artery occlusion. This is most important point, radial artery occlusion, and operator's comfort during the procedure also, lower exposure to radiation, and radial artery tortuosity, anatomical variances, subclavian tortuosity. These are the precluding successful cannulation, meaning that the limitation. And another problem is the length of the catheter. If the very tall man, then sometimes it is difficult for the length of the catheter. And the operators may have to perform coronary procedure for this tall man on the tip of the catheter, especially in the taller patients. And average dia of the radial distal radial artery is 80% of the radial artery, and there are some all like that of transradial, conventional transradial approach. So I like to show only few cases which can be done even by radial approach that we have done in transradial approach. And distal transradial access for coronary, there are several studies, interventions in everyday practice, data from triangle. They have shown that the data suggested reduced rate of radial artery occlusion. And this distal radial access, another study, they have also shown that transradial approach in distal radial approach is better than transfemoral access. And this is distal versus conventional radial, disco-radial trial. This is ongoing trial, over 1,300 patients and 12 locations in different countries, and it is going on. The target is to show that radial artery occlusion is less in distal radial approach. And this study done in National Institute of Cardiovascular Diseases, and here also we have shown that hematoma and radial artery occlusion is significantly less in distal radial approach. And there are several studies over this. And hemostasis is almost same. We can use this device, which is not available in my country. So we conventionally use this gauze and cotton pad. An example of some PCI done through distal radial approach. This is a patient. This is 5-in-6 diagnostic catheter sheath, and this is the case where there is a loop, and we have overcome this loop. And after overcoming the loop, we have done the PCI, first LAD, then LCX, and the same left catheter converted it to Judkins right, and done the right coronary artery. And before coming back, during coming back, we have checked the radial artery loop. The loop almost disappeared. And this is another case, anomalous right radial artery, though I have used Judkins left catheter, and I have done it successfully. And it is told that anomalous right coronary artery is best worked with transradial approach. This is LAD total occlusion and primary PCI, and this has been done. And this is 6-in-7 sheath, 6-in-7 sheath used in distal radial approach. And we have done this 50 years hypertensive diabetic patient. We have done decay crash in this distal radial approach with 7 French extra backup guide catheter, and the procedures as like that of decay crash, and we have done it successfully. And IVAS guided PCI, we can also, because we can introduce the sheath 6 French or 7 French, so we can do everything. That is why I want to show that IVAS guided PCI also we have done in this distal radial approach. Osteoproximal LAD deletion, and which we have done. And on the right panel, the shown IVAS, the well inflated the stent. And this is another case where I have become in problem. There is one lesion in RCA with acute marginal branch. I had no idea to save the acute marginal branch. Even then, I wanted to save, and that is why I have jailed the RCA acute marginal branch, but it did not save well. Patient become symptomatic, and then I have recrossed, and I have done TAP, and on the right panel, it is the result after TAP of the right coronary artery with acute marginal branch. And this is another case where LM to LAD, LCX and LAD is done in this same distal radial approach. On the right panel, the final result. From the viewpoint of radial artery preservation and patient's comfort, the distal radial artery is undoubtedly the best alternative choice from conventional radial approach. Its access requires a learning curve, cannulation difficulty, especially when the pulse is weak or not felt at all. With the development of material, newer techniques, sheaths, and guiding catheters, the distal transradial approach becoming the default technique for cardiac catheterization, and it's no longer a dream. Same-day hospital discharge can be done, not only same day, few hours, 4 hours to 6 hours hospital stay, and reduces the hospital cost and bed occupancy in a busy hospital like Government Hospital, National Institute of Cardiovascular Diseases. Thank you all.